Good morning, everyone. Today's topic for discussion is acute symptomatic seizures, approach and management guidelines. I am Dr. Hrudya and the session will be moderated by Dr. Manisha. In epileptology, everything comes under the broad umbrella of seizures, and it helps to understand the concept of each single term, which is defined otherwise, but definition itself is not foolproof, and it is important that we understand the concept behind it. Definitions are evolving. So the first term is epileptic seizures. The current definition was given by ILA in 2005. And every epilepsy has epileptic seizures, but every epileptic seizure does not mean that the patient has epilepsy. So it is defined as transient occurrence of signs and or symptoms due to an abnormal, excessive or synchronous activity in the brain. So an abnormal, excessive or synchronous activity in the brain itself is not enough. Patient needs to have signs and symptoms in order to be defined as epileptic seizure. Acute symptomatic seizure is a clinical seizure occurring at the time or in close temporal association with an acute CNS insult, which may be metabolic, toxic, structural, infectious, or due to inflammation. This definition was proposed by ILA Task Force in 2010. Coming to the definition of epilepsy, the conceptual definition of epilepsy was given in 2005, which is brain disorder that is characterized by an enduring predisposition of the brain to generate epileptic seizures and by the neurobiological, cognitive, psychological, and social consequences of this condition. This gives an insight into the condition of epilepsy, but by 2014, it was understood that this insightful conceptual definition is not enough for clinical practice, and they came up with an operational definition, which is epilepsy exists in a person who had at least 2 unprovoked seizures more than 24 hours apart, or who had 1 unprovoked seizure, but with a probability for recurrence of further seizures similar to the recurrence risk after 2 unprovoked seizures. That is at least 60% over the next 10 years. Or if an epileptic syndrome can be diagnosed at the onset itself. Here, one thing to notice, reflex epilepsies like photosensitive epilepsy is also included in the definition of epilepsy and is thought of as similar to unprovoked seizures. Though a clear precipitant defines the reflex epilepsies. ILA has also given the remote symptomatic seizure, which is a seizure that occurs after a latent period during which a process called epileptogenesis happens. An example for this would be late post-stroke seizure. And a progressive symptomatic seizure is when a seizure occurs due to a progressive neurodegenerative process, like in Alzheimer's dementia. Now, the process called epileptogenesis is when after the settling of the acute insult, which is due to inflammation, increased blood-brain permeability, etc., leading to an increased or decreased seizure threshold. After this period, a more permanent change involving cellular and molecular changes happens, and this increases the excitability of the brain tissue and various networks. So this permanent change is called epileptogenesis. And the present idea is that the epileptogenesis itself is a progressive process, and it recruits more and more networks into the epileptogenic zone as the time progresses. So it is a progressive process that occurs after the settling of the acute process or acute inflammation. Coming back to the definition, acute symptomatic seizure has 2 important components in the definition. Acute CNS insult has to be there, and the seizure has to occur at the time or in close temporal association with it. So each of these are not foolproof, and there are certain caveats when we look into the definition. For example, the acute CNS insult and close temporal association means that the seizure happens within a defined time after the insult, when the insult is still deemed acute. But the time cutoffs are not universal and is different for each insult. And in less studied insults, less studied CNS insults, these are often arbitrary. Next one is the transient nature of the cause and absence of enduring predisposition. In lesions causing structural brain pathologies, this is also not the case because these are not exactly transient. Then the presence of a clear identifiable cause. Brain can have an underlying predisposition that may confuse the determination of the real cause in certain cases. Coming to the etiology of acute symptomatic seizure, this is the pie chart given in a recent review article published in 2022. The major etiologies are the cerebrovascular disease, head trauma, CNS infection, and drug withdrawal, all of which accounts for approximately 15 to 16% in the whole etiology of acute symptomatic seizures. Then we also have metabolic causes, toxic causes, and some other causes as well. This is a more exhaustive list. Structural brain lesions include stroke, which includes ischemic stroke, intracranial hemorrhage, and venous sinus thrombosis and SAH. It can be because of head trauma, any neurosurgical operation, or the presence of a brain lesion or tumor. Toxic metabolic causes include hypocalcemia, magnesemia, or hyponatremia. Also, hypernatremia can cause seizures. Metabolic alkalosis, hypoglycemia and hyperglycemia, hyperammonemia, uremia and hemodialysis, alcohol abuse and certain drugs like cocaine, amphetamines and cannabinoids, and some medications, inflammation like brain abscess and other inflammatory encephalitis, immune encephalitis, hypoxic encephalopathy, hypertensive encephalopathy, eclampsia, hypo and hyperthyroidism can also lead to acute symptomatic seizures. So when we look at the phrase at the time or in close temporal association, this is defined differently in each etiology. So it is defined as the time period between the CNS insult and 7 days after that in cases of CVA, traumatic brain injury, including an intracranial surgery, in case of CNS infections, within 7 days of a multiple sclerosis relapse, and in cerebral anoxic injury. In alcohol withdrawal, seizure must occur within 7 to 48 hours of the last drink in order to qualify it as an acute symptomatic seizure. And subdural hematoma without a non-trauma, more longer intervals can be permitted. That is, if it is not due to a trauma, it can be because of etiologies like coagulopathy. In that case, we expect an ongoing leak or ongoing bleed. And so the time period specified for acute symptomatic etiology or acute symptomatic seizure is more prolonged, can be more prolonged if the SDH is without trauma. Then in arteriovenous malformation bleed, when the hemorrhage is acute, in CNS infections, usually it is during active infection. For example, in neurocysticercosis, if the imaging identifies at least one parasite in the transitional or degenerative phase, then the seizure qualifies as acute symptomatic seizure. In malaria, when it is accompanied by fever, in cerebral tuberculoma and brain abscess, when the patient is undergoing treatment, and in HIV infection during acute infection, or when there is a severe metabolic disturbance. In autoimmune disease, when there is evidence of activation of the disease, when the disease is active, that is when the seizure qualifies as an acute symptomatic seizure. Then in congenital toxoplasmosis and CJD, there is no acute symptomatic seizure. All seizures are remote symptomatic. In febrile seizure is another example of acute symptomatic seizure when the rectal temperature is more than 101 degree Fahrenheit. Coming to metabolic and electrolyte disturbances, based on some arbitrary cutoffs only partially supported by evidence. So the cutoff beyond which or below which hyponatremia can cause acute symptomatic seizure or hypomagnesemia can cause acute symptomatic seizure is well defined by ILA, but the foundation of data over which this stands is often arbitrary. The propensity of metabolic disturbances to cause seizure actually depends on the rapidity with which the disturbance develops and less on the absolute value itself. But how rapid should the fall be is not well defined. Within 24 hours of acute disturbance, if the time of onset is known, which is most often not the case, the time of onset is not usually known, then the blood sample upon which the classification is based should reflect the time of seizure operationally within 24 hours of the seizure. That is, sample should be taken within 24 hours of the seizure. Then some other facts or other things included in the recommendation for a definition of acute symptomatic seizure, based on which the ILA definition of acute symptomatic seizure is the seizure in the setting of two causes. That is, if the patient already had an old traumatic brain injury and now has an acute stroke, then if one acute CNS insult is there, then the seizure would classify as acute symptomatic seizure. And there is a term called dose effect, which states that with more severe injury, there will be a higher risk of seizure. And the insult to acute symptomatic seizure time window is also etiology dependent. The incidence of acute symptomatic seizure is 29 to 39 per 1 lakh population per year. Acute symptomatic seizures account for 40% of all cases of febrile seizures in developed countries. 73% of acute symptomatic seizure in individuals more than 18 years of age are associated with stroke. This is based on a recent 2024 article. Then acute symptomatic seizure and educational evidence-based reviews. Based on this only, I have prepared the following slides. The risk of acute symptomatic seizure in different etiology. So after development of a CNS insult, we need to know how much is the risk to develop an acute symptomatic seizure. And after development of acute symptomatic seizure, we need to know what is the risk of developing another seizure and what is the risk of developing an epilepsy in that patient. So based on the etiology, in ischemic stroke, the risk for acute symptomatic seizure is relatively low. It is only 3 to 6%. And the risk factors for this include cortical lesion and a bigger lesion size, secondary hemorrhagic transformation, severe stroke, infections, premorbid. If there are so many comorbidities in the patient, that adds to the risk of patient developing acute symptomatic seizure, and large artery atherosclerosis. Then in hemorrhagic stroke, the risk is high. That is 10 to 18% risk is there. Again, cortical lesion, high bleed volume, midline shift, MC aneurysm rupture in SAH are all risk factors. Cerebral venous thrombosis has a very high risk. That is up to 40% of cases can present with seizure. Again, hemorrhagic lesion, thrombosis of superior sagittal sinus and cortical veins. And if the patient has motor deficits, these are risk factors. In viral encephalitis, the risk is very high, especially if the patient has depressed level of consciousness, cortical lesions, and if the etiology is herpes simplex virus 1. In bacterial meningitis, also the risk is high, 17 to 27%. In autoimmune encephalitis, this is a very heterogeneous group, so the risk is also very variable. It can range from 33% to 100%, especially in cases with anti-NMDA antibody, anti-GABA A and anti-GABA B receptor antibodies, and anti-LGI1 receptor antibodies. Brain trauma has moderate risk of developing acute symptomatic seizure, that is 2 to 15%, especially if the patient has skull fracture, penetrating injury, and intracranial hemorrhage, and if there is a need for neurosurgical intervention, and in younger patients. In hyponatremia, the risk is very low. It is 55% only. And lower the levels of serum sodium, more acute the development of hyponatremia, more is the risk. In posterior reversible encephalopathy syndrome, the risk is very high, 60 to 75%. And in anoxic encephalopathy also, up to 1/3 of patients can develop acute symptomatic seizure. Now coming to the risk of developing a second seizure after the first acute symptomatic seizure. This is also different for different etiologies. In stroke, again, this includes all kinds of stroke. So an average risk of 33% is there for a second seizure development after an acute symptomatic seizure. In case of traumatic brain injury, it is 13.4%. And in case of a CNS infection, again, a very heterogeneous group, the seizure recurrence risk is 16.6%. Risk of developing epilepsy after acute symptomatic seizure. This is very important. This is the data based on which long-term anti-seizure medication strategy has to be determined in each etiology. So various studies are there. Mostly in ischemic stroke, the risk for development of an epilepsy after an acute symptomatic seizure is in the range of 40 to 60%. So in intracranial hemorrhage, though the risk of developing an acute symptomatic seizure is high in the acute phase, the risk of going into development of an epilepsy is lesser than that in ischemic stroke. That is 27 to 44% in one study and 32% in another 2016 study. In SAH, the risk of developing epilepsy was found to be 36% and 40% in SDH. In certain autoimmune encephalitis like anti-GAD65 and anti-MA2 and anti-WHO antibody-related encephalitis, the risk of it going into developing an epilepsy if the patient had an acute symptomatic seizure is very high. That is up to 60 to 80%. But though the definition of epilepsy says that if the risk of developing an epilepsy is more than 60%, it has to be classified as epilepsy. But still, the first seizure during the acute phase in this acute autoimmune encephalitis condition is still classified as acute symptomatic seizures. Again, CNS infections together with bacterial and viral, the risk is 13 to 22%. But in HSV encephalitis alone, the risk of developing epilepsy later on is 40 to 65%. In traumatic brain injury, again, the risk of going into epilepsy is very high, 75 to 80%. In PRESS, though the risk of an acute symptomatic seizure is very high, there is very less chance of it going into epilepsy. Management guidelines in acute symptomatic seizure. There is an absence of clear, comprehensive and cohesive guidelines for the management of acute symptomatic seizure with anti-seizure medication, especially their duration of use. It's not clearly mentioned and we don't have any very clear guidelines on this. Probably because the acute symptomatic seizures are usually managed by either neurologists other than epileptologists or by a physician, because the setting of acute symptomatic seizure is when another etiology is more important to deal with, and that is often done by a non-epileptologist. So probably that is the reason why we don't have many studies and we don't yet have proper clear guidelines on when to start ASMs or when to discontinue ASMs in the OPD follow-up. This is a recent article, Anti-Seizure Medication Use in Acute Symptomatic Seizures. This has compiled all the data regarding the anti-seizure medication duration of use, the current practices, what is being followed, and whatever guidelines is currently available. So the key recommendations so far are, so the patient has to be evaluated for provoking factor after the first seizure. The patient has to be clearly evaluated even if the CNS insult is not apparent during the presentation. This is based on expert opinion. Then video EEG monitoring during seizure-like activity can be used to differentiate it from PNES. Findings most predictive of a seizure like tongue biting, head turning, or twisting can help in differentiating from PNE. Assess for history of medication or substance use that can provoke seizures through normal use. Some medications can cause seizures even when the level of drug is within the therapeutic range. Order an MRI or neuroimaging study under epilepsy protocol may also be advised along with EEG after the acute symptomatic seizure also. Though the guideline is for first unprovoked seizure, we often investigate an acute symptomatic seizure also with EEG and neuroimaging. Recommended anti-seizure medication for patients with high risk of seizure recurrence. For those patients, anti-seizure medication is recommended. And consider anti-seizure medication to reduce the risk of seizure recurrence by more than 1/3 at 2 years after seizure. So current practice trends, which is compiled in the article I have mentioned previously, that multicenter studies show that 70% of patients with clinical and acute symptomatic seizure and 95% with electrographical seizure, whenever EEG monitoring was done, they were on anti-seizure medication at the time of discharge. 70 to 90% of patients with the acute symptomatic seizure after traumatic brain injury remains on anti-seizure medication even after 1 year of acute CNS insult. And 25% of the neurologists continue anti-seizure medication for 1 to 3 months after the discharge. 33% continue for 4 to 6 months, and 25% tends to continue the anti-seizure medication for 6 months after acute symptomatic seizure. Approach to a patient presenting with suspected acute symptomatic seizure. Though the reason for the CNS insult may not be apparent at the time of acute symptomatic seizure, we have to thoroughly investigate for the presence of a CNS insult when the patient is presenting with the first seizure. Detailed semiology from the person who witnessed the event, whenever possible, has to be taken. Though the semiology is representative of a symptomatic zone and not exactly the ictal onset zone, but it might help in determining whether it is a focal seizure or a generalized seizure, might help in determining whether it is more symptomatic or then unprovoked. Because most of the CNS insult in the initial phase tends to give rise to focal seizures. Medication history has to be thorough. Possibility of drug abuse, including alcohol and that of drug overdose, has to be taken. Then presence of fever, headache, and vomiting has to be asked for. Encephalopathy prior to seizure. New onset neurological weakness prior to seizure has also to be asked for. In an examination, stigmata of drug abuse, CLD, CKD, diabetic stigmata, fever, meningeal signs, skin rashes, complete neurological examination to look for new onset neurological deficits, and other involuntary movements, if they are present or not. This is important because the other involuntary movements may be mistakenly referred to as seizures by the bystander. Then investigation including metabolic panel, electrolytes, and blood sugars. Everything has to be done if the history and examination is not suggestive of one particular etiology. Even otherwise, metabolic panel, electrolytes, and blood sugars has to be done for every patient. Then tox screen, EEG and neuroimaging, though it is not clearly recommended anywhere, EEG and neuroimaging is also used in investigation of most of the acute symptomatic seizure. Then CSF study is if indicated, autoimmune panel and paraneoplastic panel if indicated. EEG helps in distinguishing seizures from non-epileptic attacks, identifying non-convulsive status epilepticus, in showing diffuse flowing of background rhythms, non-specific abnormality, which may be seen post-ictally, especially in case of a traumatic brain, in case of a structural pathology. in showing focal slowing or periodic lateralizing epileptiform discharges which occur with any localized pathology, including viral encephalitis, tumor, or vascular events. So whether or not EEG findings add to the clinical knowledge in predicting outcomes after an acute symptomatic seizure was explored in this study. And the result is that when a continuous EEG monitoring is performed in patients after acute symptomatic seizure, the majority of seizures, that is approximately 75% of them, were exclusively non-convulsive. EEG can identify highly epileptiform patterns that are also strongly associated with later epilepsy. Both non-convulsive seizures and lateralized periodic discharges are major risk factors for development of new epilepsy. So the result is that EEG findings add to the clinical knowledge in predicting the prognosis of the patient or in predicting whether the patient will go on to develop epilepsy. So in acute symptomatic seizure or in acute brain injuries, or even in the absence of a motor seizure in an unattended patient, EEG might be of value in prognosis as well as guiding anti-seizure medication continuation or discontinuation later in the course. But exactly how long is recommended is not yet finalized or defined. So coming to the long-term anti-seizure medication in acute symptomatic seizure, this is from a recent review that I had already mentioned, anti-seizure medication use in acute symptomatic seizure. So they have proposed a new way of seeing or dealing with the acute symptomatic seizure. They have proposed that we divide the etiology based on whether it causes acute hyperexcitability, subacute hyperexcitability, or prolonged hyperexcitability, and then determine the prolongation of anti-seizure medication therapy based on that. So acute hyperexcitability is when hyperexcitability lasts for hours to a couple of days. And subacute hyperexcitability is when it lasts for days to up to a week. And prolonged is when weeks to months hyperexcitability lasts. So factors affecting seizure risk after insult is reversibility of pathology, and location and severity also affects. So based on the above mentioned categorization, the etiologies that comes under acute hyperexcitability and settles soon after that is electrolyte imbalance, hypo or hyperglycemia, medications, alcohol withdrawal, and other toxemias. Whereas an subacute hyperexcitability is associated in severe sepsis, septic shock, press, and also in RCVS. Prolonged hyperexcitability is seen in structural pathologies like stroke, intracranial hemorrhage, or traumatic brain injury. So based on this, what they have proposed is in acute hyperexcitability, anti-seizure medication after an acute symptomatic seizure may not even be needed. We only have to deal with the acute insult, like an acute hyponatremia. We just have to correct it and not start on any anti-seizure medication beyond the acute management of seizure. So even if it is started, it has to be given only for days until the dyselectrolytemia settles. In case of subacute hyperexcitability, again, in these cases, for the duration of hospitalization only, anti-seizure medication is proposed. Then in case of prolonged hyperexcitability, anti-seizure medication is definitely indicated, and the proposal is to reassess the patient at 3 to 6 month interval after discharge. These are not recommendations, these are proposed suggestions as to when to discontinue anti-seizure medication. Coming to particular etiologies, in alcohol, there is a risk of developing acute symptomatic seizure when the patient is in a state of withdrawal, also when the patient is intoxicated with alcohol, and in certain situations, even after the withdrawal, that is 7 to 48 hours, that is specified as the risk of developing acute symptomatic seizure. Even beyond that, the excitability can persist. So we will look into all this. Severe alcohol withdrawal symptoms should receive prophylactic pharmacological treatment. So as of now, there is a recommendation to give primary prophylaxis to prevent the occurrence of acute symptomatic seizure if the patient has severe alcohol withdrawal symptoms and not in mild or moderate alcohol withdrawal symptoms. That is, in most patients admitted with alcohol withdrawal symptoms, we have to start them on primary prophylaxis, mostly with benzodiazepines like lorazepam. Primary prophylaxis during detoxification is also indicated. And this has to be done with long-acting benzodiazepines. Secondary prophylaxis after first acute symptomatic seizure, we can give a short duration of lorazepam. This is similar to the primary prophylaxis. So whether or not the patient has acute symptomatic seizure, the patient is in a state of severe alcohol withdrawal, we can give anti-seizure medication until the withdrawal state settles. Then if the patient has seizures associated with alcohol intoxication, there is no clear definition to start on a prophylactic course of anti-seizure medication. The recommendation is only to treat the seizure acutely. Then there is an entity called SESA, which is subacute encephalopathy with seizures in alcoholics. In this case, seizures may not have temporal association with withdrawal or cessation. And in that case, after the occurrence of a seizure, but this condition only occurs in heavy alcoholics. And in that case, secondary prophylaxis for weeks is required. Again, for how many weeks is not specified. Coming to drug-induced seizure, certain drugs can cause seizures when the level is within the therapeutic range. Examples for this would be tricyclic antidepressants, some SNRIs like venlafaxine, some SSRIs like fluoxetine and sertraline, antibiotics, fluoroquinolones, metronidazole, some analgesics like tramadol, fentanyl, intrathecal morphine, then anesthetics like sevoflurane and propofol, anti-asthmatics like theophylline, some immunosuppressants like cyclosporine, etc. can have a very low risk of precipitating seizures even when the drug level is within the therapeutic range. So if that is the case, the only thing we need to do is withhold the likely culprit drug once other causes are ruled out. And if the patient is presenting with a drug overdose, or if the patient has used drugs of abuse, then we have to immediately initiate methods to fasten the elimination of the drug from the body, and a short course of anti-seizure medication may be used. There is no clear recommendation for the use. So first line is benzodiazepine is what we usually use. Second line, if this fails, we can go ahead with barbiturates or traditional anti-seizure medication like levetiracetam. Phenytoin is to be avoided because of a risk of paradoxical seizures, especially in cases of alcohol withdrawal or after lidocaine, theophylline, or tricyclic antidepressant usage. Again, duration of therapy is roughly said as a period when the drug is still persistent in the body and until it is completely eliminated from the body. That is, at the time of discharge, patient can be discontinued on anti-seizure medication. Now, coming to a case scenario, this is an 84-year-old woman who was found unconscious on the floor of her flat and was brought to hospital. The patient has a history of hypertension and is on ramipril and hydrochlorothiazide for it, as CKD, and a previous documented episode of hyponatremia also. There is no history of seizure or other neurological diseases in the past, and she was living alone. There was no cognitive decline. In the neurological emergency room, she developed generalized tonic-clonic seizure and remained unresponsive thereafter. This was her first seizure. For the EEG in this case, the MRI only shows some degenerative changes, and the EEG shows a diffuse slowing, and the serum sodium was found to be 108 millimole per liter. So coming to electrolyte disturbances, acute treatment beyond acute management is not recommended. If at all ASM is started, then it is recommended to stop once a dyselectrolytemia settles. So we may not even start anti-seizure medication Even if we start, it has to be stopped once the dyselectrolytemia settles. So the cutoffs that I have already mentioned previously, that there are certain cutoffs given below which the dyselectrolytemia can be regarded as causative for acute symptomatic seizure. But again, this is arbitrary and different studies have used different cutoffs. In case of sodium, most studies agree that below 115, if a patient develops seizure, then it can be classified as acute symptomatic seizure. And in case of calcium, less than 5, magnesium, there are certain studies, and what we have adopted or ILAE has adopted is these cutoffs based on this study by Beggy et al. So for serum glucose, below 36 milligram per deciliter hypoglycemia or more than 450 is the cutoff with ketoacidosis. In case of serum sodium, less than 115. In case of serum calcium, less than 5. Magnesium, less than 0.8. And blood urea nitrogen, more than 100. And creatinine, more than 10. Again, the thing that has to be kept in mind is rapidity with which the dyselectrolytemia develops is most of the times more important than the cutoff value. And so the clinical judgment is more important in determining the cause of the seizure. Yes, ma'am. Patients with no, the premorbid condition matters. But the patient with hepatic encephalopathy, because two etiologies are acting in the. You are asking to differentiate between uremic and hepatic encephalopathy. Uremic. My guess would be uremic encephalopathy, because in kidney diseases, other electrolytes also. Ammonia. Yes. Now coming to another etiology, in eclampsia, we usually manage eclampsia with magnesium sulfate compared to other anti-seizure medications are not usually used. This is proven by studies, but the mechanism by which this is more superior is not completely known. The magnesium sulfate lowers the seizure recurrence rate and reduces maternal mortality compared to standard anti-seizure medications. Primary prophylaxis is indicated in an established preeclampsia case during labor and for 12 to 24 hours postpartum. Secondary prophylaxis is continued for 24 hours after delivery or 24 hours following the last seizure, whichever is later. This is another case, a 48-year-old woman with history of one episode of unresponsiveness. Patient had been treated for hypertension and hyperlipidemia in the past and had been smoking 15 cigarettes per day for last 20 years. Reported that she had felt numbness in her left arm for 2 minutes but could not remember what had happened thereafter. The patient's daughter had noticed her sudden staring motionless without any response for 1 minute, appeared confused after the event briefly. And the neurological deficit has persisted after the suspected seizure as well. So MRI brain showed multiple acute cortical ischemic lesions on DWI in the right MCA territory, particularly in the posterior third. And MR angiography revealed a high-grade stenosis of right internal carotid artery. So the EEG is showing focal slowing in the right. There is asymmetric slowing in the right frontotemporal region in the EEG done after the event. So coming to ischemic stroke as the cause for acute symptomatic seizure. So we had earlier seen that a recent review has suggested almost 73% of all acute symptomatic seizures are because of stroke. In ischemic stroke, 25 to 60% are because of ischemic stroke. Incidence range is very much different in different types of stroke. In ischemic stroke, it is 1.3%. In intracerebral or subarachnoid hemorrhage, it is 4%, and up to 34 to 40% in case of a cerebral venous thrombosis. And 50 to 70%, that is most of the acute symptomatic seizure occur within the first 48 hours after the onset of stroke. The mechanisms is for acute symptomatic seizures in a stroke is increased inflammatory response, change in neuronal signaling related to protein synthesis, increased excitatory neurotransmitter. So there is a excitotoxic milieu in the areas affected by the stroke. So this is giving rise to a decreased seizure threshold. There is, apart from that, there is ionic imbalance, increased blood-brain barrier permeability, breakdown of membrane phospholipids, and release of free fatty acids and oxidative stress, which all contributes to the excitotoxic environment. And predictors of acute symptomatic seizures after stroke. This we have already seen from a previous slide. Focal seizures are more common in the acute symptomatic stage, whereas as it becomes late seizures, that is after 7 days, or when it can be classified as unprovoked seizure, more chance of patient presenting with a generalized seizure is there. Now, which ASM to use? Based on certain studies, the efficacy seems to be similar for lamotrigine, levetiracetam, and sustained release carbamazepine, and less ADRs are there for lamotrigine and levetiracetam than compared to carbamazepine. This is also supported by the normally preferred anti-seizure medication in case of a focal seizure based on the Sanand study, which is again lamotrigine. Again, there is a mention that statins has anti-seizure action, probably by the inflammatory milieu is calmed down by the statins. So statins also help in reducing the seizure incidence. EEG predictors of unprovoked seizures during the first year after stroke. So it is important to know what to look for in EEG and what predicts the formation of or the process of epileptogenesis and later developing an epilepsy. The first EEG showing background activity asymmetric. Like we have already seen from our previous case, there is an asymmetric slowing and the occurrence of indirectal epileptiform activities in the first EEG after stroke predicts the development of epilepsy. Increased risk for developing epilepsy in the post-stroke period. No EEG abnormality independently predicts acute symptomatic seizure, however. Continuous EEG monitoring is not recommended anywhere, but may be used in case of larger lesions, particularly cortical strokes, and in case of SAH, the amount of blood in the basal cistern correlates with the seizure risk due to irritation and inflammation. The risk of a second acute symptomatic seizure after the first one is 10 to 20%, and 10-year risk for another seizure or unprovoked seizure is 30%. This data we have already seen from previous slides. Coming to the SELECT score, this was a score devised to predict the development of epilepsy after stroke. The components of this score are severity of stroke. If the stroke is more severe, that is more than 11, is the NIH's, the score given is 2. In case of large artery atherosclerosis, there is increased risk. In early seizures or acute symptomatic seizure, if the patient had, there is higher risk. If there is cortical involvement associated with higher risk, and if MCA territory is involved, then there is a higher risk. The risk of epilepsy after stroke based on the SELECT scores are, it becomes more than 60 if the SELECT score is more than 8 at 5 years. So this is a very recent paper published in June 2025 regarding the role of EEG in predicting post-stroke seizure. So they have proposed another score called SELECT EEG score, which apart from the parameters of the SELECT score also includes electrographical parameters like regional slowing will get 1 point, and if at all there is epileptiform activity, then that will get 1 point. So the total score becomes 8 compared to 6. This is only proposed. So later on, EEG parameters might also add to a routine management of acute symptomatic seizure after stroke. So cortical venous thrombosis, it can be the presenting symptom in 40% cases. The risk factors are supratentorial, hemorrhagic lesion, deficits, if the patient has motor and sensory deficits, and thrombosis of superior sagittal, sinus, and cortical veins. And the seizure predict the outcome in cortical venous thrombosis. In intracranial hemorrhages, a score called CAVE can be used. It has 4 components: cortical involvement, whether or not it is present, age less than 65, volume more than 10 ml, and presence of an early seizure or acute symptomatic seizure. Based on the score, the risk for developing late seizure, that is unprovoked seizure, is given. So in intracranial seizure, there is a study which found that levetiracetam was effective in preventing electrographical seizure. So ASMs that we typically use is levetiracetam. Phenytoin may worsen the cognitive outcome, but other standard anti-seizure medications like lamotrigine, carbamazepine may also be utilized in treatment of seizure after the acute symptomatic seizure and intracranial hemorrhage. In case of a subarachnoid hemorrhage, the risk is higher if SIH is associated with poor neurological grade on admission. The rupture aneurysm is in the middle cerebral artery. If there is hydrocephalus, aneurysmal SIH itself is more riskier to develop acute symptomatic seizure, and if there is a cortical infarction. There is no recommendation for primary prophylaxis, especially if there is absence of high-risk factors. Anti-seizure medication after the first seizure has to be stopped after 7 days, according to the guidelines. So the drugs that have been studied are phenytoin, valproate, and levetiracetam, and mostly the studies are favoring levetiracetam. Coming to the posterior reversible encephalopathy syndrome, the acute symptomatic seizure is very common in these patients, though the risk of developing a later epilepsy is less. Anti-seizure medications are typically used to prevent recurrent seizures and discontinued at the time of hospital discharge. And studies also support this. Once the acute clinical and neuroimaging, we can stop anti-seizure medication. There is no need to continue anti-seizure medication in the OPD follow-up also. Coming to CNS infections, meningitis, encephalitis, abscess, and subdural to acute symptomatic seizure. and it is seen in 20 to 40% of cases with the CNS infections. Viral encephalitis is 14 times more likely to cause than bacterial encephalitis, especially HSV encephalitis. 60% of risk of developing and acute symptomatic seizure is there. In Japanese encephalitis also, very high risk is reported. In bacterial meningitis, there is high risk is there, but not very high. Like in viral meningitis, the risk factors are decreased consciousness on admission, positive CSF culture, and CSF cell count lower than 1,000 cells, elevated CSF protein, and focal abnormalities on brain imaging. In neurocysticercosis, this we have already mentioned, in the presence of a degenerative cyst with edema, that is when the seizure, if at all it develops, classifies as acute symptomatic seizure. There is no recommendation for primary prophylaxis in CNS infections also, whatever be the infection. Anti-seizure medication are typically initiated after first seizure and continued for 6 to 12 months. Though the recommendation clearly says that once the acute infection itself settles, we can discontinue with the anti-seizure medication. Most of the current practice trends suggest that it is continued for longer duration, up to 3 to 6 months. It is stopped only after reassessing, often with the ancillary test like EEG. Then only the clinicians usually tend to discontinue the anti-seizure medication. Then coming to autoimmune diseases of CNS, risk is dependent on the brain regions involved, particularly high in case of limbic encephalitis. So autoimmune encephalitis, as we know, is the most commonly identified cause of NORS, or new onset refractory status epilepticus. Most often implicated are anti-NMDA, GABA B and A receptor, anti-LGI1. With the exception of LGI1 and GABA A receptor encephalitis, the risk for recurrent seizure after acute inflammatory phase is low. So epileptic seizures in the systemic autoimmune conditions like SLE, 15% of patients may develop epileptic seizure in case of SLE. And only 12% had recurrent seizure. One seizure is seen in many patients, but recurrence risk is less. Acute symptomatic seizure of varying types have been reported in 70 to 80% of steroid responsive encephalopathy associated with the thyroid disorder patient, and status epilepticus was seen in 10 to 20%. In autoimmune diseases, two different entities are described. One ASSAE is acute symptomatic seizure secondary to autoimmune encephalitis, that is during the phase of inflammation. In this case, there can be initial resistance to anti-seizure medication, but the patient responds very well to immunotherapy, and there will be acute inflammation on imaging. There is almost nil risk factor for epilepsy. And then there is autoimmune associated epilepsy. That is because of a process of epileptogenesis happening. That is apoptosis, gliosis, and structural injury leading to persistent seizure or development of epilepsy. Once this happens, it becomes resistant to both anti-seizure medication and immunotherapy. And this is especially common if the patient has other comorbid autoimmune conditions as well, other systemic autoimmune conditions as well. In ASSAE, immunotherapy for 6 to 12 weeks is recommended. That is, normal treatment for autoimmune etiology has to be done. The patient responds in 4 to 6 weeks usually. ASMs are continued for a variable period from 3 months to 1 year. And which ASM to use is sodium channel medications are demonstrated to be of better seizure control than other ASMs in this case. That is carbamazepine, oxcarbazepine, lacosamide, and phenytoin. This ASSAE is the one that qualifies as acute symptomatic seizure in case of an autoimmune encephalitis. This is the case of a 28-year-old male found in an unconscious state after he had lost control of his motorcycle and went off-road. Initially, due to the poor GCS, he was intubated at a primary care center and shifted later to a tertiary care hospital. Had brief episodes of uprolling of eyes with brief posturing of all four limbs for few seconds. On examination, had a very poor GCS, even VTM3, sluggishly reactive pupils bilaterally, and there was right parietal cephalometoma. CSF autoria from right side was also there. And CT brain showed SAH with left frontal and temporal. SDH was also there with mass effect. Left frontotemporoparatal hematoma with mass effect, and cerebral edema was also there. So in a traumatic brain injury, this is the only condition of acute symptomatic or expected acute symptomatic seizure where primary prophylaxis is recommended. Primary prophylaxis for 7 days is recommended. Phenytoin or levetiracetam are the drugs that are usually used based on the current studies, based on the current practice trends. Factors increasing the risk of developing acute symptomatic seizure in traumatic brain injuries, elevated risk of acute symptomatic seizure in general, and that of NCSC in particular is there in traumatic brain injury, especially if there is a high burden of comorbidities. That is already, if the patient has some underlying condition that makes the seizure threshold come down. And infectious complications such as pneumonias, especially when associated with fever or systemic inflammation, also confers increased risk in traumatic brain injury. Febrile seizures in childhood are also considered as acute symptomatic seizure. Typically ages 6 months to 5 years of age, not caused by CNS infection or metabolic disturbance, has to be ruled out. And the rectal temperature is usually more than 101 degree Fahrenheit at the time of developing seizure. It occurs in 2 to 5% of children, and lifetime risk of developing epilepsy is only 2 to 6%, and peak incidence is at 18 months. It can be simple febrile seizure or complex febrile seizure. And the management for simple febrile seizure is we manage the fever alone, and a prophylactic anti-seizure medication which has to be given during a fever episode may be prescribed. Complex focal seizure has to be assessed more thoroughly, looking for any neurological deficits, and further imaging and EEG is indicated in these patients. Longer duration. So these are the features of complex febrile seizures, and the risk factors are age less than 15 months, epilepsy or febrile seizure in first grade relatives, first episode presenting as complex febrile seizure. Risk of recurrence based on the number of risk factors. Based on these risk factors, if only one risk factor is there, then there's 25% of recurrence. And if two risk factors are there, 50% of recurrence. And then 3 to 4%, 80% of recurrence is there. So summarizing, the present recommendations are there for these conditions alone. In ischemic stroke, the European Society has recommended that anti-seizure they do not recommend anti-seizure medication even after the first episode of acute seizure, acute symptomatic seizure, as the chance for developing a further epilepsy or further seizure is very less. So they recommend not to use anti-seizure medication after a single acute symptomatic seizure. But what we usually follow is the AHA or ASA recommendation to use anti-seizure medication for a short duration after the first acute symptomatic seizure. In case of an intracerebral hemorrhage, there is recommendation to use anti-seizure medication after acute symptomatic. Subarachnoid hemorrhage also, treatment with anti-seizure medication for less than 7 days after acute symptomatic seizure is reasonable by the AHA-ASA guidelines. In case of alcohol withdrawal, the American Society of Addiction Medicine has recommended to use benzodiazepines as first-line treatment And benzodiazepines are preferred to phenobarbital. This level A evidence. And European Society has also recommended to use lorazepam or diazepam for primary prevention. As we have already seen, in case of severe withdrawal, we can use drugs for primary prevention. And benzodiazepines, usually till the withdrawal symptoms settle. This is mostly about the acute symptomatic seizure alone, which classifies as the early post-stroke seizure within the first 7 days. Usually, 1 to 4 weeks is what we usually use. 21 days. Yes. There is no strict recommendation as to when. And then in eclampsia also there are guidelines. Magnesium sulfate is to be used for 24 hours after delivery and or 24 hours following the last seizure. So basically summarizing, ILAE recommends that acute symptomatic seizure only requires short-term anti-seizure medication. So primary prophylaxis is not indicated to prevent acute symptomatic seizure in any cases except in severe traumatic brain injury. And there is no evidence for anti-seizure medication possessing any anti-epileptogenic potential. So there is no basis for continuing anti-seizure medication for longer period after symptomatic seizure. And evidence is lacking on which ASM to choose and how long to continue in most cases. Will the number of acute symptomatic seizure affect the duration of anti-seizure medication usage? Should every patient of acute symptomatic seizure be evaluated with EEG? These are yet to be answered. Thank you. Watershed. MRI check followed by embolic. Venous infarcts are highly reflective. One, because they are more of cortical. Second, there is hemocycle. More than arterial infarct, venous infarcts are lower. So hemocycle is highly reflective for the brain. So whenever you have hemocycle in a long term, like a cavernoma, those all have hemocycle which increases that does not have to be the otherwise cortical arterial. And hemorrhagic infarct, the basic ganglia is not. That is why you are receiving hemorrhagic is less compared to the classic then Addison report has the maximum for seizure as compared to the
she has covered everything very well. So acute symptomatic seizures usually or with the have a temporal association with the insult to the cerebrum. As she has clearly told, it depends on the age also. Like in neonates or infants, you see more of infections which are more common in that group. So encephalitis, then you see hypoxic insults, and along with that you see metabolic issues also more in neonates like hypoglycemia. Then when coming to adult group and early adult group, you have the trauma and then autoimmune encephalitis that can be there with middle-aged group and elderly also. Along with that, you have the alcohol withdrawal and drug withdrawal. And when you go to very elderly age group, you have the stroke. Along with that, the metabolic issues are also there. So the type of acute symptomatic seizure etiology depends mainly on the age group of each of these patients. The next important question is how many of them have the risk of recurrent seizures and how many of them finally go on to develop epilepsy. That depends on various factors, age of the presentation and the type of presentation. If the patient has initial presentation as an NCSC or a status or recurrent seizures or prolonged seizures, they have higher risk compared to the brief acute asymptomatic seizures which you see. Then if there is an MRI abnormality, like if there is a hypoxic insult with a huge MRI abnormality, and in case of etiology of the stroke, actually in stroke, highest risk is for CVT followed by hemorrhagic, not ischemic. Ischemic, even though there are majority of cases and have very high incidence, the chance of acute symptomatic seizures are higher in hemorrhagic as compared to either thrombotic or embolic. However, the long-term risk of developing epilepsy, as she has told, is higher for ischemic strokes. So the type of etiology or the type of stroke matters, and the cortical location, all these things matter. Then the other important thing is the EEG abnormality. In the EEG abnormalities, in the acute phase, most important thing is to rule out electrographic seizures or NCSC, and also if there are PLUDs, like lateralized periodic discharges or PLUDs plus, or if there is an asymmetry or EEG abnormalities, each of these have corresponding risk for developing epilepsy or like increased risk of seizures. Lateralized periodic discharges plus and ictal patterns like electrographic seizures and NCSC have higher risk compared to just a plain asymmetry or epileptiform discharges. So EEG is another important factor which you have to see to predict the risk of developing epilepsy in future. So how to go about the management is, it depends mainly again on the each scenario. It's not a hard and fast rule. For example, if it is a metabolic insult, as long as you're treating the dyselectrolytemia, you need not treat sometimes with anti-seizure medication, or once the insult is over, you can immediately stop the anti-seizure medication. If it is an encephalitis like in children, even though current trends suggest using the anti-seizure medications for 6 to 12 months, pediatric guidelines and AOCP guidelines, all of them recommend that if the child is seizure-free for at least 72 hours, and if the EEG is normal, and if the child is normal, MRI is normal, you have to stop the anti-seizure medication before the child is discharged. As the risk of anti-seizure medication, which is mostly phenobarbital in this group, is higher than what the child will have because of the seizure. Anyway, the long-term risk is having an epilepsy after a latent period. So even if you give an anti-seizure medication continually during this period, latent period is usually 6 to 7 months. Even if you continue, the risk of the side effects of the drug is more than what you're going to like decrease the risk of epilepsy in the long term. And the type of epilepsy would be different, and you would have to treat with a different anti-seizure medication. Like most of them would sometimes develop epileptic spasms, at which phenobarbital would be of no use. So you need to like focus on this aspect, and especially in neonatal cases, after 72 hours, if patient is seizure free, you taper off and stop the ASM. But it is a completely different scenario if the child is abnormal, like if there is global developmental delay or MRI abnormality, that it warrants a long-term usage. So the type is like, this is how you manage based on the scenario. And she has told the durations very clearly. Coming to the important durations, for traumatic brain injury, guidelines recommend, like whatever studies are there, expert opinions recommend, only 2 weeks, primary prophylaxis for 7 days, and management of acute symptomatic seizure for 2 weeks is enough, as long as there is no risk of developing epilepsy. Again, if there is epilepsy, a gliotic focus, you would have to treat it like an unprovoked seizure and a long-term epilepsy. Then in stroke, early post-stroke seizures for less than 7 days has a different mechanism as compared to long-term, like late post-stroke seizures, where the mechanism is mainly the synaptogenesis and the gliotic focus. So in the early ones, it's mainly inflammation. So the guidelines recommend 1 to 4 weeks only. There is no clear-cut indication that a particular number, some 20-21 days is given. It's mentioned as 1 to 4 weeks from whatever we have seen. Then in case of long-term cases, like in post-stroke seizures which are late, you would treat again it as unprovoked seizure. You have to do serial EEGs. Based on that, if the patient has again cortical infarct and if the initial presentation was a status, you would have to treat for 2 to 5 years, depending on each individual scenario, and then assess. So that would become like how you manage a routine epilepsy in case of late post-stroke seizures. So these are some of the conditions in which the guidelines have been given briefly or based on the RCTs available. Then medication, coming to this, only in stroke, a lot of research has been done. Levetiracetam and lamotrigine and carbamazepine are the ones usually preferred. And among that also, levetiracetam and lamotrigine are shown, but there is no difference in the efficacy between these drugs. And even zonisamide is being used. Phenytoin has also been used previously. And traumatic brain injury, as she has told, levetiracetam is preferred. And phenytoin is also another drug which has been commonly used. The other newer drugs haven't been studied adequately in trials, so we cannot tell how far efficacious and how they have the risk to decrease epilepsy in the long run. So these are some of the things which are important in acute symptomatic seizures.
The session has come to an end. Thank you for the patient listening.